Hello, Namaste students. Today we will discuss about respiratory system examination. So what are the cardinal symptoms of respiratory system? The cardinal symptoms of respiratory system are cough, hemoptysis, breathlessness and chest pain. Of these four cardinal symptoms, students, we have already discussed about breathlessness and chest pain in cardiovascular system examination. So today we discuss about cough and hemoptysis. So first we'll discuss about cough. Cough is a forced expiration against a closed glottis. It is a protective mechanism. There are afferent receptors in the pharynx, larynx, airways, down the parenchyma, and also in the lower part of the esophagus, as well as Arnold nerve of vagus. Arnold nerve of vagus supplies the external auditory canal, a little part there. So not only the airways, even the lower part of esophagus and Arnold nerve has afferent receptors for cough. Which are the afferent receptors for cough? Vanilla type 1 receptor and C fibers are the afferent receptors for cough. From these afferent receptors, the impulse will traverse to the vagus nerve. From the vagus nerve, the impulse will traverse to the nucleus of tractus solitarius. From there, the impulse will be sent to the vocal cords. So, after a deep inspiration, the vocal cords will adapt. Then there will be a forced expiration against a closed glottis, generating pressure as high as 300 mm of Hg. So this is the cough reflex. Pharynx, larynx, lower end of esophagus, lung parenchyma, Arnold nerve has vanilla type 1 receptors as well as C fibers. From there, impulse will go to the vagus nerve, nucleus of tractus solitarius. From there, it will send an impulse to the vocal cords to adapt, and then there will be a forced expiration against a closed glottis. It's a protective reflex, cough reflex. Depending upon the duration, the cough can be classified into acute, subacute and chronic. Less than 3 weeks, 3 to 8 weeks, more than 8 weeks. The causes for an acute cough of duration less than 3 weeks are usually infections, respiratory tract infections, either viral or bacterial. The cause for subacute 3 to 8 weeks are usually a post-infective reactive airway syndrome. Patient will recover from the infection, but still because of the irritation, the cough may persist from 3 to 8 weeks. The causes for chronic cough more than 8 weeks duration are COPD, interstitial lung disease, in a developing country like India, tuberculosis, and a more serious cause like bronchogenic carcinoma. So students, cough depending upon duration is divided into acute, subacute and chronic. Less than 3 weeks infective, 3 to 8 weeks post-infective airway reactivity, more than 8 weeks tuberculosis, COPD, ILD and malignancies. Now, in some conditions, chest examination may be normal, X-ray may be normal, but still patient continues to have cough. What are the 4 causes for this picture where examination will be normal and chest X-ray also will be normal? Drug-induced cough, AC, angiotensin converting enzyme inhibitors, drug-induced cough, postnasal drainage, gastroesophageal reflux disease, cough variant asthma. We'll discuss one by one, students. First is angiotensin converting enzyme inhibitor induced cough. It occurs in 5 to 30% of the population. Why is angiotensin converting enzyme inhibitor will inhibit the metabolism of bradykinin and substance P? The increased level of bradykinin and substance P will induce the cough. The angiotensin converting enzyme inhibitor induced cough is not dose related, and if you give angiotensin receptor antagonist, this cough doesn't come. If you stop the angiotensin converting enzyme inhibitor for more than 1 month, if still the cough persists, then it rules out angiotensin converting enzyme inhibitor as a cause of cough. So that's about angiotensin converting enzyme inhibitor induced cough. Next is gastroesophageal refluxes. So gastroesophageal reflux, the gastric content can reflux back to the lower end of esophagus. It can irritate the lower end of esophagus. As I told in the cough reflex, there are afferent receptors present in the lower end of esophagus which can produce cough. Sometimes the gastroesophageal reflux can be till the level of pharynx. It can go to the trachea, producing chemical pneumonitis and tracheitis. Gastroesophageal reflux patients will have a heartburn after eating the food and unrecommended position and lying down. The next is postnasal drainage. Postnasal drainage of any etiology can produce a cough because it can irritate the pharynx. Sometimes the postnasal drainage can go till the larynx and it can irritate there also. Patient usually will have frequent clearance. He will be frequently clearing the secretions. There will be rhinitis and pharynx will show cobblestone appearance. Cough variant asthma usually occurs in the children more than adults, where the patient won't have chest tightness, breathlessness, no wheeze. Now, all these etiologies, the chest X-ray is normal, general physical examination is normal, you can treat it. Angiotensin converting enzyme inhibitor cough, you can stop the drug. Cough variant asthma promptly responds to the inhalation beta 2 agonist and steroids. Gastroesophageal reflux, you can give antacids, proton pump inhibitors. Gastroesophageal reflux disease, you can give antacids and proton pump inhibitors. And for postnasal drainage, you can give antihistaminics. This is a treatment of a chest findings are not there and chest X-ray is normal, but still patient continues to have cough. If you treat all these conditions, if still patient continues to have cough, where X-ray can be normal, there are some conditions which you should think X-ray can be normal, but still cough can persist. Which are those conditions? Bronchiectasis, tumor, interstitial lung disease, atypical mycobacteria, pulmonary tuberculosis, sarcoidosis, lymphoma. So bronchiectasis, tumor, early stage, interstitial lung disease, atypical mycobacteria, pulmonary tuberculosis, sarcoidosis and lymphoma, X-ray can be normal in the initial stages. So students, cough, when you ask the symptom, it can be dry or productive. If it is productive, you have to ask some questions in the sputum. What is the color of the sputum? The color of the sputum, if it is yellow, it is a suppurative bacterial infection. If it is green, Pseudomonas infection. In a Klebsiella pneumonia, it can be a red currant jelly. In the Streptococcus pneumonia, it is a rusty sputum. You get pink frothy sputum in pulmonary edema, pink frothy sputum. Onchocerciasis you may get in amoebic liver abscess, rupturing into the bronchus. And black color sputum you get in Kohlberger's pneumoconiosis. So color. Next is quantity. If the sputum production is more than 100 ml per day, it is known as bronchoria. The condition which produces bronchoria are bronchoalveolar carcinoma, necrotizing pneumonias, suppurative lung disease like bronchiectasis and lung abscess, empyema rupturing into the bronchus. You can have a large amount of sputum production. Next is consistency. Sputum can be a serous, mucoid or purulent. Serous you get in bronchoalveolar carcinoma and pulmonary edema. Mucoid you get in bronchial asthma and chronic bronchitis. Purulent, you get in suppurative lung diseases, bacterial infections. Then postural variation of the cough you should ask. In bronchiectasis and lung abscess, if your patient lies down on the uninvolved lung, for the involved lung secretions can come and irritate the normal mucosa, they may get cough, postural variation. Then you have to ask foul color smelling sputum. Foul color smelling sputum you get in bronchiectasis and lung abscess. Then 3-layered sputum. If you keep the sputum for 24 hours in bronchiectasis, you will get a 3-layer. Upper layer serous, middle mucus, the lower one purulent. Then what are the conditions producing nocturnal cough? Nocturnal cough is a feature of congestive heart failure, left ventricular failure, bronchial asthma, chronic bronchitis, postnasal drainage, aspiration, tropical eosinophilia. So the nocturnal cough you get in left ventricular failure, a bronchial asthma, aspiration, tropical eosinophilia, chronic bronchitis. Then what is brassy cough? Brassy cough is whenever the airway is pressed upon by a tumor, will have a metallic quality, that is brassy cough. Then bovine cough. Bovine cough you get in recurrent laryngeal nerve palsy. The explosive quality to the cough will be lost in a bovine cough because of left recurrent laryngeal nerve palsy, bovine cough. So these are some few points about cough, students. The next symptom is hemoptysis. Hemoptysis is the presence of blood in the sputum. Hemoptysis should be distinguished from epistaxis and hemoptysis. There are few points which can distinguish a hemoptysis from hemoptysis. Usually hemoptysis is preceded by cough, hemoptysis is preceded by vomiting. The color of the blood in hemoptysis is red, bright red, whereas hemoptysis is dark because of acid mixture with the blood acid hematine formation. Because it comes from the airways, in hemoptysis it can be frothy, so it is not frothy in hemoptysis. pH will be acidic in hemoptysis, it will be alkaline in hemoptysis. Usually there are preceding lung problem in hemoptysis, bleeding peptic ulcer in hemoptysis. What are the causes of hemoptysis? Systematically you can go for approach of a causes of hemoptysis from lung parenchyma till the larynx. Hemorrhage into the alveoli called diffuse alveolar hemorrhage can occur DAH. It could be due to inflammatory or non-inflammatory causes. The inflammatory causes could be due to vasculitis like SLE, Wood-Pasteur syndrome, or initial 100 days of bone marrow transplantation. Could be non-inflammatory due to thermal injury, toxic inhalation and cocaine abuse. The bleeding in diffuse alveolar hemorrhage is from the capillaries. Unlike the bleeding from a medium and small airways where the bleeding is from a bronchial arteries at a systemic pressure. The commonest cause of hemoptysis is a medium-sized airway infection, that is bronchitis, acute bronchitis. Pneumonia of any cause can have hemoptysis like Streptococcus pneumonia, Klebsiella and Staph aureus. Mycobacterium tuberculosis produces hemoptysis by Rasmussen's aneurysm rupture, which are nothing but the dilatation of the pulmonary arteries in the tubercular cavities. The most feared cause of hemoptysis, that to massive hemoptysis, is bronchogenic carcinoma, especially the proximal airway bronchogenic carcinomas like small cell carcinoma and squamous cell carcinoma. The tumors can bleed into the hilar vessels, they can produce a massive hemoptysis. Hemoptysis is classified into is known to be massive hemoptysis when the amount is more than 500 ml per day or 150 ml per hour or 100 ml for consecutive 3 days. So 500 ml per day, 150 ml per hour or 100 ml per 3 days. There is one entity catamenial hemoptysis. During each month menstruation period, there is hemoptysis due to the endometriosis. Pulmonary embolism can produce hemoptysis, pulmonary edema can produce hemoptysis, and pulmonary AV malformations can produce hemoptysis. Carcinoid tumors can produce hemoptysis. In the alveolar causes, if the patient is taking antiplatelets, anticoagulants, any irritation of the alveoli, as I discussed, noxious stimulus, thermal injury can produce hemoptysis. Dear students, endemic hemoptysis is produced by Paragnomus westermani, a lung fluke, which is endemic in Southeast Asia, China. Spurious hemoptysis is hemoptysis occurring from the upper respiratory tract above the larynx. And pseudohemoptysis, you get in pigmentation by sedation. How do you approach a case of hemoptysis? How do you manage it? Students, hemoptysis, if a patient with hemoptysis is there, you examine him, history and physical examination. First, you rule out whether it is hematomesis or bleeding from oropharynx. Okay, that you have to rule out. Then it can be a non-massive or massive. If it is a non-massive, if no risk factors like smoking, okay, then just treat the underlying cause. If still persistent bleeding, then go to this workup. If risk factor is there, more than 40 years and smoker and hemoptysis, then do chest x-ray, urine analysis, because to rule out Goodpasture syndrome, there may be hematuria, creatinine level and coagulation studies you have to do. If nothing yields, go ahead with CT scan and bronchoscopy, then treat the underlying cause. If still bleeding persists, go with embolization or resection. If there is a massive bleeding, then you will first protect the airway. The dependent lung, the normal lung should be, the affected lung should be downwards. Okay, it should be affected lung should be down. Then you can use double lumen endotracheal tube with the affected lung put a proximal blockage so that the blood should not go into the normal lung. So you have to protect the airway. If bleeding stops, well and good. If bleeding continues, if a massive hemoptysis, do embolization or resection. This is how you manage a case of hemoptysis. So now let us go on to the examination of a respiratory system. Okay, proper inspection, palpation, percussion, auscultation.